Okay, so now we're going to talk about hypothyroidism and hyperthyroidism, and then hypo and hyperparathyroidism. The parathyroidism. That's a tongue twister. Let's start with hypothyroidism. Hypothyroidism occurs when there is a decreased metabolism from low levels of thyroid hormones. So this can happen with low ingestion of iodine or tyrosine, if somebody has thyroid surgery, if they receive radioactive iodine. Risk factors include women typically between 30 and 60, and women are 7 to 10 times more likely than men to get hypothyroidism. Hypothyroidism, the symptoms include cool, dry, coarse skin, dry, brittle hair, decreased hair growth, poor wound healing, hypoventilation, dyspnea, decreased heart rate, enlarged heart, decreased blood pressure, decreased body temperature, cold intolerance. So somebody would be inappropriately dressed warmly for the weather. So if it's 90 degrees outside, wearing a parka or a sweatshirt or something like that. Patients with hypothyroidism can also experience depression, paranoia, and apathy, decreased libido, decreased urine output, a thick tongue, puffy face, abdominal distension, constipation, confusion, slowing of their intellect, decreased activity tolerance, fatigue, slow metabolism, and weight gain. Man, this sounds like so much fun. With hypothyroidism, you monitor their respiratory status, their cardiac status, and their cognitive status. Upon evaluating these patients, they're going to have decreased levels of both T3 and T4, while the thyroid stimulating hormone will be increased in primary hypothyroidism and decreased in secondary or tertiary hypothyroidism. So the normal ranges, and I'll show this to you in just a second, the normal ranges for T3 hormone levels are 70 to 205, T4 are 4 to 12, and TSH, which is the thyroid stimulating hormone, are 2 to 10. So with hypothyroidism, T3 and T4 will be low, TSH will be high in primary and low in secondary or tertiary. And there are those numbers for T3, T4, and TSH. Hopefully this is not blurry for you. I don't know. For hypothyroidism, the drug treatment of choice is going to be lifelong thyroid hormone replacement. So if somebody's had their thyroid removed, they're obviously going to need external supplement of thyroid hormone. So the drug is called levothyroxine sodium. I'm probably not saying that right, but I'll show it to you what it looks like. Patients with this will start with the lowest dose. They typically will start low and then taper up to get to whatever is their therapeutic dose range. If they get too much of the thyroid hormone replacement, they could go into hyperthyroidism. So this is the name of that drug, levothyroxine sodium. Hopefully I'm saying that right, but I'm probably not. Who knows? For this drug, you tell your patient to take it in the morning with no food. You also need to teach them the signs and symptoms of hyperthyroidism, which we're literally about to get to. They need to avoid taking sedatives. They need to take measures to prevent constipation, so increasing their fluid intake, increasing their fiber intake, increasing activity. And they should not switch brands of the medication. So if they started off with a generic, they need to stay with that generic of the medicine. If they started off with a brand name, they need to stay with that brand name, just because the drug can have different little inactive molecules in it that you don't want them to take. That could affect them differently. So with hypothyroidism, you teach them the signs of hyperthyroidism, because they could go into that if they receive too much of the thyroid hormone replacement. So hyperthyroidism is excessive thyroid hormone secretion. It's more likely to occur in women, just like the hypo one. This can be either temporary or permanent. Graves' disease can occur with hyperthyroidism. It doesn't happen all the time, but Graves' disease is a toxic diffuse goiter, so like an enlarged thyroid. This can result from Hashimoto's thyroiditis, which is such a fun thing to say, Hashimoto's thyroiditis. The symptoms of hyperthyroidism are hypermetabolism, increased SNS activity, so sympathetic nervous system, increased heart rate, increased stroke volume, goiter, excessive sweating, fine thin hair, rapid or shallow breaths, blurred double vision, increased tears and an enlarged spleen, tremors, insomnia, increased libido, decreased attention, manic behavior, fatigue, a low-grade fever, which can lead to heat intolerance, weight loss, increased stools, increased appetite. Hyperthyroidism, the symptoms are called thyrotoxosis. I can't say that right. But think of it kind of like you're stepping on the gas pedal. Like everything is speeding up. The metabolism is speeding up. So since the metabolism is speeding up, the patient's going to experience weight loss. Because they're going to experience weight loss, they're going to have an increased appetite. The increased weight loss can lead to an increased heart rate. Increased heart rate can lead to excessive sweating, which can lead to rapid or shallow breaths, which can lead to blurred double vision. Like it all is just kind of relates back to each other. But remember, hyperthyroidism is like you're stepping on the gas, you're speeding everything up, while hypothyroidism is you're stepping on the brakes, slowing it all down. So with hyperthyroidism, a phenomenon can occur called a thyroid storm. This is when excessive amounts of the hormone are released. There's extreme signs and symptoms that are like life-threatening arrhythmias, shock, respiratory failure. For this, you treat the patient by giving them oxygen. You give them propranolol. Can never say that correctly. You increase the PTU dose, which we'll talk about in just a second. You can give them sodium iodine. You can give them hydrocortisone. There's just different things that you can use to treat a thyroid storm. So with hyperthyroidism, the T3 and T4 will be elevated, and the TSH level will be low in Graves' disease and high in tertiary and secondary hyperthyroidism. So remember, hypo, T3, T4 were low, and TS was high, and then low in secondary and tertiary. With hyper, T3, T4 are elevated, TSH is low in Graves, high in second or tertiary. So it's kind of like the inverse of all of this stuff. So just remember, T3, T4, high, hyper, T3, T4, low, hypo. Just, that's what I kind of think of. You can also perform a thyroid scan on these patients to see if they have a goiter, like an ultrasound on their thyroid. And there's different drugs that you can give these patients. First of all, you can give them a thionamide. I hope I said that right, but Lord knows I don't ever say it right. That's methimazole. This one's not approved for use in pregnancy, but Parathyroidism, which is called PTU, it can be given in pregnancy, but it can also lead to liver toxicity. So there's pros and cons to both of these drugs. You can give patients iodine, which is for a short-term therapy. You can give them a beta-adrenergic blocking drug like propranolol, which helps with their heart rate. You can give them radioactive iodine. You can give them surgery. You can give them potassium iodine or Lugol's solution, which will decrease the vascularity of the thyroid before surgery. So like if you know that they're going to have their thyroid removed in a month, they would start giving them those medicines, one of those medicines like 2 weeks in advance to decrease the vascularity of the thyroid, because the thyroid would bleed a whole lot. But with patients receiving these things, like especially if they're receiving radioactive iodine, you do need to teach them like radioactive precautions. So like flushing the toilet 3 times after they've gone to the bathroom for like a week after they've taken the treatment, avoiding contact with pregnant women, children, and infants for a week after they've taken it, washing their clothes separately, and then running a load of hot water in the washing machine after they've washed their clothes, using disposable utensils and tissues, taking a laxative or drugs to help prevent constipation, to rid the bowel movement in their body that could have radioactive particles in it. There's different things that you would teach them, but that is if they're receiving the radioactive iodine. For these patients that could be receiving or that are receiving surgery on their thyroid because it is right here in their throat, you do want to maintain an airway after surgery. So this would include having oxygen at the bedside, having suction at the bedside, and also having a tracheotomy tray at the bedside, just in case something should happen where you need to maintain their airway. You have those things all ready to go. Those are things that go along with hyperthyroidism. Remember, hyper, you're stepping on the gas, everything is speeding up, increased metabolism, and all the stuff that goes along with it. And then hypo, you're stepping on the brake and everything is slowing down. So with hypothyroidism, T3, T4 are low, and hyper, T3, T4 are high. So T3, T4, low, hypo, T3, T4, high, hyper. So that can help you with that kind of stuff. Now we're going to talk about parathyroidism, specifically hyper and hypo. Let's start with hypo. Hypoparathyroidism is a lack of PTH, which is parathyroid hormone, which can lead to hypocalcemia. Risk factors include surgical or radiation-induced thyroid ablation. So if they've had surgery on their thyroid or radiation there. Parathyroidectomy, so having part of their thyroid removed. Congenital dysgenesis. Idiopathic hypoparathyroidism, so something that's like an autoimmune disease attacking their parathyroid. Hypomagnesemia. This is like a tongue twister. Hypomagnesemia, so low magnesium levels in their blood. I mean, I know what it means, it's just I can't say the words. Symptoms of hypoparathyroidism are going to include excessive muscle contractions, Chotsky's sign, which is a facial response, like when you like stroke their cheek right here, they're gonna do this. They're gonna like blink and like their lip is gonna come up or whatever. That's at least kind of what our teacher showed us. Like I think if you just touch it, it does that. I don't know. It's kind of funny. Trousseau's sign, where like if you're doing their blood pressure, their arm is gonna flex back like this. That's kind of weird, but like it comes back like that. That's Trousseau's. Both of those things will be positive, like if you test for that. Patients who have hypoparathyroidism will also have tingling or numbness. They'll be irritable. They could have psychosis. And there's 3 different types of hypoparathyroidism. One is iatrogenic, there's idiopathic, and there's hypomagnesemia. Iatrogenic is where there's the total removal of the parathyroid. Idiopathic, this one is most likely autoimmune related. And then hypomagnesemia can be because of malabsorption, chronic kidney disease, or malnutrition. So I'll show you how to spell those words right here. Those are the 3 different types of hypoparathyroidism. With hypoparathyroidism, the patient will have increased levels of phosphorus, but they will have decreased levels of calcium, magnesium, parathyroid hormone, which is PTH, vitamin D, and urine CAMP. The decreased urine CAMP level is what confirms the diagnosis of hypoparathyroidism. So remember, increased phosphorus, decreased calcium, magnesium, parathyroid hormone or PTH, vitamin D, and urine CAMP. Those things will all be decreased, and that decreased urine CAMP level is what's going to confirm the diagnosis of hypoparathyroidism. For these patients, you can also give them an EEG, CT scans, and blood tests to, obviously you need a blood test to see all those different levels. For these patients, the drug therapy, at first they're going to be receiving like an IV calcium, like calcium chloride or calcium gluconate, and then they're going to be on calcium PO for the rest of their life. At first, they'll be given vitamin D, like oral calcitrol, but then they'll be put on ergocalciferol PO for life. So at first, they're giving all these IV drugs that are trying to get the calcium and vitamin D into their body really quickly. And then once they've maintained that level, once they've reached the like therapeutic level that they need, then they're going to maintain it with oral meds for the rest of their life. For this patient, you want to teach them to increase calcium and vitamin D in their diet, but you do not want to increase phosphorus in their diet. So when you say, oh, you need to increase calcium and vitamin D in your diet, people are going to be like, oh, sweet, I can have ice cream and cheese. But you can't, because ice cream, cheese, other dairy products also have phosphorus in them, and you don't want to increase phosphorus levels. So you got to say, sorry, you cannot have dairy. You can get your calcium from like dark green leafy vegetables or like a calcium supplement. So hypoparathyroidism, your goal is to increase the calcium levels, increase vitamin D, but you don't want to increase phosphorus. You want to like decrease it. So you can't tell your patient, hey, go eat a whole bunch of dairy. You cannot tell them that. So no dairy. You got to get your calcium from dark green leafy vegetables. Yay, kale. So fun. That's it for hypoparathyroidism. Now we're going to get hyper. Hyperparathyroidism causes hypercalcemia, hypophosphatemia. So kind of like the opposite over at hypoparathyroidism. We're now at hyper. Hyper patients will have low phosphorus levels, but increased calcium, increased magnesium, increased parathyroid hormone, which is PTH, and increased urine CAMP, which will also confirm the diagnosis of hyperparathyroidism. Patients with hyperparathyroidism, since they have increased blood calcium and decreased phosphate blood levels, they will have, sorry, I had to get those words out of my brain. They will most likely have, their symptoms will be bone fractures, weight loss, arthritis. They could have kidney stones. They could have GI issues like nausea and constipation. The risk factors for hyperparathyroidism include parathyroid tumors or cancers, congenital hyperplasia, neck trauma or radiation, which is where your parathyroid is, vitamin D deficiency, chronic kidney disease with hypocalcemia, parathyroid hormone, which is like, no, wait, take this back. Parathyroid hormone secreting cancers of the lungs, kidneys, or the GI tract. So something that is secreting parathyroid hormone somewhere else in the body, like a cancer in your lung or a cancer in your GI tract. Obviously, if it's secreting PTH, then it's going to increase the PTH level in your body. So again, hyperparathyroidism, the patient's going to have low phosphorus, high calcium, high magnesium, high parathyroid hormone, which is PTH, and high urine CAMP, which the high urine CAMP confirms the diagnosis of hyperparathyroidism. For this patient, the drug therapy of choice is diuretics and hydration therapy. So like furosemide, which is the goal is to excrete the calcium that they have overloaded in their body. So you, of course, since you're dealing with calcium, you need to prevent fractures. So, wait, I'm trying to think of what I want to say here. You need to prevent fractures. So like teaching them like movement and like increasing calcium in your increasing your exercise, like to help. I can't use the words that I want to say, but you need to prevent fractures because of the decreased bone density. So you need to teach them exercises that can help them prevent fractures. With this, you need to monitor their heart function during their hydration therapy because you don't want their electrolytes and their fluids to get out of whack. And I've just used a whole bunch of words, and I'm just going to show you the drug words that I have written down here because it's furosemide, but there's also Sincalcet, and oral phosphates. The overall goal of those drugs are to excrete calcium, but who knows how to say them correctly. Lord knows I don't. But the main thing here is with hyperparathyroidism, they have decreased phosphorus, and all of these things over here are increased, with urine CAMP being the confirming the diagnosis. And hypoparathyroidism, all of those things are decreased. Phosphorus is increased. Look, this one also has vitamin D. This one doesn't. Hyperparathyroidism doesn't really deal with that, but hypo does. So urine CAMP is the thing that is the confirming diagnosis for both of these things. I hope this helps. Who knows? I don't know. Maybe it will.